think the issue of tort reform is one that has been sort of discussed on the sidelines. There was a record of President Obama indicating his willingness to look at it. I think there was a recognition it was a standalone issue that had to be dealt separately, not in the context of health care reform, and I myself look forward to a discussion around that.
Why not? Why not? You want to do a comprehensive package that's going to reduce the health care costs that everyone pays. So that would be a major savings.
Resident of Hudson, I have a more detailed question on the medical review boards. The question around this has mainly been, will they be denying care? Now, President Obama has already said they will recommend best practices, but he has not directly answered the question, will they harbor or deny direct care? And the examples that I would use is, if you are a certain age, will a particular procedure be denied? You in your report that you handed out to us speak about unnecessary treatments. And I'd like to hear, one, what's your statement on the medical review boards and what's included in the term unnecessary treatments?
That's a good question, and I think you're referring to the comparative effectiveness entity that would gather data. If you look at the language in the bill, it clearly states that it will not drive or be required to drive decision-making. It is absolutely a neutral reference point in which all the information comes together, analysis is made as to what works, what doesn't work, all those kinds of things. It will be transparent to doctors, it will be transparent to patients. My guess is it'll be up online for any one of us to go to look at it as we are making decisions around our care. In terms of the unnecessary use of whatever, my point really was that often, for example, there are duplicative tests made. That you go to one doctor who orders one test, you go to a second doctor who doesn't know that the first doctor has ordered that test and orders the same test. All those things add cost into the system. One of the reasons we're having electronic record keeping is so that if the first physician orders a test, the information is there, then made available to any other physician that you choose to have it available to. I would have to say, to tell another story, I visited a physician once, this has to be like almost 8 years ago, in a hospital that was well ahead of many today. They had the resources to do it. I had a blood test upstairs. By the time I was downstairs to the second physician, he already had the results. He knew what the outcome was, and it saved a lot of my time. It saved a lot of his time, and I felt that I was in the hands of people who actually knew whatever, my health condition was, and that it was a great benefit to the system. We are really talking about that kind of thing that encourages the transfer of information between physicians that are caring for you, maintaining your privacy all along, and avoiding the duplication of some of these tests that in the end simply cost more money than is necessary.
Congresswoman, we are so blessed to have you. I'm talking about paying for it. I'm talking about taxing benefits. I don't earn a lot of money. I have a wonderful employer who pays for my health coverage. That is just a little more than half the cash that I get. The equivalent to tax benefits seems aggressive to me. To the people who might need it the most. How do you stand?
The House, we rejected that. The Senate is currently considering that proposal, but looking at what they call gold-plated benefits. I have yet to see any numbers around it. I'm generally not supportive of it, especially if it ends up being regressive. There is, however, data out there that suggests that by taxing benefits, or at least the high end of benefits, the very high end, that it forces us all to think about what we're asking for, what we're paying for. But at this point, it's not on the table. Nothing that I've seen that I could support. So I agree that it is essentially regressive.
So I'm also very concerned about cost, and is this echoing? I'm not certain. Am I too close?
It's not bad. I can hear it. I don't know about other.
Yeah. It's unfortunately true that about 30 to 40% of premiums that people pay to health insurance companies are spent for administrative expenses and not for health care. And that's probably the biggest reason why it costs so much to get health care in this country. This is not true in most of the countries in Europe, which have some form of single-payer health care, and have done away with that. And they have better outcomes. They have much better outcomes. If you look at infant mortality rates, if you look at longevity, life expectancy, we are not at the top of the world. We're down around number 47 or 48. We don't get good results. The wealthiest third of American citizens have about the same or worse health on average than the poorest third of British citizens. And yes, right, this is exactly leading to my question. So I would like to know how we can possibly achieve, and by the way, and their costs in Europe are about half or less per capita for healthcare than we pay here. And they've done this because they can do away with those insurance company administrative costs. And I would like to know how we can achieve that kind of health care for all our citizens without some kind of single-payer plan that does away with the insurance company.
It isn't single payer, but the public option is a government-run insurance program that people can choose for all of those reasons if they wish. So if you see significant savings in it because the administrative costs are kept way down, and as a result those are translated into lower insurance premiums, and you're content with the coverage that it's going to provide for you, then that is a choice that you have. But there are those who ardently are single payer, and because they do see tremendous savings as a result of it. And yet, as you can see, we have a system that is based on employer-based insurance. It is something people value very much. It's something that they've lived with and understand, and there are many, many people in this country quite unwilling to give it up. And so we are trying to fashion a reform effort that really is built upon employer-based insurance, strengthens that in the course of it, and at the same time creates an option that people can migrate to if they wish. But also, let's just take a quick look at Medicare, which is struggling with the rising cost of care as much as anybody else in this country, doesn't have the high overhead, doesn't have the huge administrative costs, and still very much a challenge to the federal budget. So yes, administrative costs alone can make some difference, but they are not the sole issue that we are contending with as a nation.
Dr. Cong, thanks for your time. I got two quick questions here. One right off of your Medicare comment here. If Congress is so concerned about health care costs, why not fix Medicare first? President Obama himself stated that there was $400 billion of cost savings to be had in Medicare, although I'm not quite sure where he came up with that number or what's behind it. But with the massive budget blowout that we have right now, why not try to realize the savings first? So that's my first question. Second question, as you stated earlier, in states, there are lots of states with only two insurers for health insurance, but the reason there's only two is because they have a deal with the state governments to restrict competition in that state. So would you favor having true competition of insurers from state to state and portability of insurance plans? Something we don't have right now.
No, we don't. In fact, I was taking a hard look at the insurance plan that I'm the beneficiary of because it comes up so much as an issue in the course of this discussion. And it turns out that as a federal employee, as I was saying, every federal employee has the same sort of insurance choices, whether you're mailman or me or somebody working in a federal prison or whatever, at NIH, a scientist at NIH, you have the same choices. And it turns out what I had, when I went in to see the HR person when I was soon elected, I chose the one that made the most sense for me. And I liked it because it was a national plan. There were 6 national plans, and I liked it because I knew I could get treated in Washington or I could get treated back in Massachusetts without having to worry about all the various issues. So you have 6 national plans within that system, and then you have a multitude of state plans, state-regulated plans. So, yes, I think we have to be sure that we have national plans that are available as a choice. On the other hand, you know, in Massachusetts, we've had some wonderful experimentation with some of our not-for-profit plans that have led the way in many regards, and so there's something to be said for the more local plans as well. I would look at that. Well, that's because as we initiated the Massachusetts plan, created the connector, gave people more choice, subsidized those who couldn't afford it, but did not deal with the underlying issue of the cost of care across the system. That is a second issue and a very important one, which is why you had a recent commission come forward and say, for example, we have to look at the way in which we pay our physicians, in particular fee-for-service models. So it's an underlying issue and one that was Massachusetts the legislature chose to avoid at that point, but it's come back to bite us, and now we have to take a look at it. But I think we have to take a look at broader insurance issues. I'm grateful for the insurance reforms that are in this legislation, though. I think it's because it's not unlike some of the challenges we're facing as we wrestle with the cost of care here in Massachusetts. You do these things in isolation, and it is not as successful as doing it across the healthcare delivery system. So I think the feeling has been, and we have a moment in time where we can move forward, and we may not have it again for quite some time.
Yeah, I have a suggestion and a question. My suggestion is, because there's no one plan now, my suggestion is, when there's a bill that you're ready to vote on, that you come back here before you vote and tell us what your vote's going to be, because if you're not going to vote with us, then we can vote you out. And if you're going to vote for us, then we'll vote you out. And that's with the understanding that the House of Representatives doesn't pass it at midnight, and Pelosi wants it voted on at 6 in the morning.
Well,
My question is this, Mrs. Tsongas.
Yes.
I've looked at your voting record. You voted for PAP. It was supposed to do something, it didn't. You voted? No. Let me finish. You voted for the stimulus package. Today, my team for the Department of Transportation came out. They have 50 projects that they've identified. It's on their website. Cost them millions. They're not even eligible for the stimulus, but they got the money anyway. So why should anybody, believe you or anybody else in Congress, you didn't do it right in those 2 instances, what the hell are you going to make? You think you're going to get it right now? You vote with them 98% of the time. Please answer the question. Think you're going to get it right?
Well, the electoral process is a process by which citizens do come and judge their members of Congress. I made those votes both based on what I thought was in the best interest of the people I represent. We had a failing financial system that required very quick response so that the system would not collapse. That's number one. We have an extraordinary challenge to our economy that all economists agreed we, as the federal government, was the actor of last resort, and that we had to take, this is the lesson of the Great Depression, we had to take very serious action to prevent our economy from falling further. And we're seeing the results of that most aggressive one-time action. I defend those votes. Difference of opinion as to what is the best way to proceed as a country. As when I was first elected to Congress, a person who will go nameless said this would be a great job if you didn't have to vote. But reality is we have to vote. We have to make decisions based on the information we have, on the philosophical assumptions underlying our what we offer to bring to office, and then we go back and we get measured by all of you. It's a most dynamic process. Not a simple or easy one, but what a country because of it.
First of all, I think the record needs to be set straight. The administration has actually not talked about $400 billion, but $1 trillion that they would like to see cut out of Medicare and Medicaid. The question I have is, in light of the fact that, the comment about the National Healthcare Advisory Board, that this was stuck in the night before it was supposed to be taken up by Congress, by Obama administration. Excuse me, can I finish my question? Thank you. What Ezekiel Emanuel, Obama's go-to person on this question of health care, along with others in the administration, have cited NICE in England, National Institute for Clinical Excellence, as a model. And the importance, and Obama himself has said this should be something we put on steroids, not just kind of a group that comments on cost-benefit analysis, that he wants to cut costs. My concern is that if you look at the effect, for example, in England, I had a friend of mine who fought for 2 years to stay alive with lung cancer, 2 years after they were supposed to not be alive. And in England, the mortality rate, I've heard different numbers. It's dramatically higher. The mortality rate is higher for cancer than here, whatever flaws we have. Now, with that kind of model, if our administration is using this as a model, what we're talking about is you may not see the dead bodies. No, it is England, the National Institute for Clinical Excellence. Look it up. If we're using this as a model, my concern is we are knowingly, even if we don't have concentration camps piled up where everybody can see it, we're knowingly increasing the death rate. And I'm from Massachusetts, and the health benefit, the cost-benefit analysis is cutting support to places that you have people that can't afford health care, that can't pay for health care, places like Boston Medical. And if this is our model, my question is, how can Congress go with this kind of health rationing policy and at the same time attack the idea and not actually explain why they disagree with the idea that this is a Nazi policy?
The comparative effectiveness issue, as we've gone through it a number of times, it was something that was carefully vetted by Congress. It was not something that was stuck in the middle of the night. It's something that each committee that's had to deal with has had a hard look at. I have to tell you, when we're on the floor of the House, all we ever talk about is all the various pieces of this health care legislation. And again, it's an objective reference point, but there has to be a central place that kind of brings all this information in and analyzes it. So, and we talk about the issue. Right now, we're in a situation, this is not meant to lead to choices rationing. This is just meant to lead, we're going to do this one, or we're going to do that one, or we're going to not even look at this. There's no obligation, not one obligation to take a look at it. Coverage is not premised upon it. Nothing is premised upon it. It's a place, an objective resource for physicians and patients, so the doctor and the patient can work together to make the decisions that are best for that person's care.
Thank you.